Welcome back to another episode of the Grief Observed podcast. I'm your host, Brad Morrell. It seems like it's been forever and a day since we've had an episode. I'm glad to be back. If you would like to join me for an episode, find me on Facebook at facebook.com/Grief Observed Podcast, or send me an email at griefobservedpodcast@gmail.com. I'm also on TikTok under Grief Observed Podcast. Just reach out to me and I'll be glad to get you on an episode. Today, my guest is Dr. Alan R. Cohen. He's a pediatric neurosurgeon with more than 4 decades of experience treating critically ill children at institutions rather, including Boston Children's Hospital and Johns Hopkins. He's here today to discuss his memoir, Comfort Always: Healing in the Age of Technology. Dr. Cohen, Al, thank you for joining me today for this episode.
It's a pleasure to be here, Brad. Thanks.
Yeah, it was good. We finally connected. Here we are, and I'm really excited. Like I said, this is the first podcast I've had in a little while. Vacation, summertime, chores, things of that nature, but always glad to talk about things and here we talk about grief, and it's not always easy. And I'm certain that there's a lot of that in your business as far as families and things like that. And I certainly want to get into that aspect, but also give some space for your book today. But why don't you tell the audience a little bit more about who you are?
So I'm a pediatric neurosurgeon, which is somewhat interesting in that I never even knew that the field existed when I was in medical school. And I grew up in Poughkeepsie, New York, up the Hudson River from New York City. My dad was an eye surgeon. I always wanted to be a doctor when I was growing up. He was a strong influence in me. He took me to the OR. I got to watch some of his really cool microsurgery. But I kind of realized that if I were going to become an eye surgeon, I'd always be compared to my father. I'd never really be able to match up to that. So I decided to have to choose something else. And I became very interested in the nervous system in medical school. And I was influenced by a guy, Fred Epstein, one of my mentors, a pediatric neurosurgeon, said, I want to be like him. And so that's what I've been doing for the past 4 decades. And my particular focus has been in childhood brain tumors.
Hmm.
And childhood brain tumors have a dubious distinction. They're the number one solid tumor in children, and they're number one cause of cancer death in kids. So it's a weighty field, and we deal with some very serious problems. But if I had it to do again, I would do it over. It's a long, arduous training, but it developed very powerful long-term connections with patients and families. And it's a very unique field that most people don't know much about.
Hmm. Yeah, I admit you're going to have to enlighten me a little bit today, but I know a little bit about it. And certainly you've worked with some large name hospitals there, so I'm sure you've seen uh, cases that likely aren't. Uh, I don't know. I guess they kind of escalate up to some of the larger hospitals. You know, I hear other names. Obviously, we know St. Jude. There's Vanderbilt. There's all these bigger named hospitals, and certainly Johns Hopkins is one of the ones that rings off right off for my knowledge, and then of course Boston Children's Hospital. Um, do you feel like you see some of the worst cases or most challenging cases, perhaps?
Every case is different. And what I've done here in my job, I tend to write and speak for medical audiences about technology. This is the first time I've written for a general audience. And what I wanted to share is some of the unique patient stories that I've had. I sort of kept a diary over the years.
Hmm.
And some of these stories are very gripping. And it gives me a chance to talk about the art of healing that we don't speak about all that much. In fact, the focus of the book is to talk about the forgotten art of healing in the current age of technology. We can do
Hmm.
things now with technology that we couldn't even do when I started my training, and we can save a lot more kids. We can use technology to control pain and combat disease, and in many cases, prolong life. What happens though is as we focus so much on technology, if we don't manage it properly, that can have a tendency to drive a wedge between the doctor and the patient and the family. This book was an attempt to bring the public to the bedside and into the OR to show what's going on and show the importance of that complex interaction between the doctor, the patient, and the family.
Yeah. I was kind of giving you some of my medical anxieties right before we started here, and mine seem uh, rather insignificant at the moment, comparative to some of these cases that you speak of. And I'm sure it's a really scary position for a parent. I'm a parent of one daughter, now 24, and I remember when she was about 9 years old getting the diagnosis that she had juvenile arthritis. And it's like, wow, this is a challenge. But even that seems insignificant compared to a brain tumor. And these parents are getting uh, some very difficult news. How do you share that with someone? Uh, the news, and I'll ask too, do most of these children already have a prior diagnosis before they come to a hospital like yours?
Not usually. They come with symptoms and signs and have a workup. But as you point out, it is a tough diagnosis. And this is one of the most difficult things I've ever had to do to talk to a parent and tell them, I'm sorry to give you this news, but your child has a brain tumor. Because I know that that news is going to change the lives of the family and the patient forever. Nothing will ever be normal again. Even though
Hmm.
we can do a lot more now than we could before, we can cure many of these tumors and control them in cases that we can't. But it's a devastating diagnosis to give, and it doesn't get easier with time.
Hmm.
Keeps us going is that there are many cases it's hard to express how good it feels to be able to tell a family, we took the tumor out, it's benign, your child's going to be okay. And if we can't get it all out, even in a cancerous or malignant tumor, we're going to be able to control this. And we have a team that works together and life is good. So it's a difficult field. The team feels grief as we go along, as you can imagine, but we do it because the outcomes are so satisfying. And when we
Hmm.
are able to return a child back to his or her life, it's a very gratifying thing. It's much more emotionally impactful than anything you could ever watch on one of these TV shows about medicine.
Hmm. Yeah, and you clued the listeners in that, after 40 years, you would do this all over again. And that's pretty powerful, despite the news that you may have to deliver to a parent. And like you're stating, there's moments of reward. And I know it's not about self, but it's more about bringing life back to a family, to a child. And certainly the rewards have to impact you as well there. That's great.
One of the nice things about being an older pediatric neurosurgeon is number one, I tended to forget some of the arduous days and nights of my training decades ago. But number two, I get to see my patients grow up, and some
Hmm.
of them are now adults with children of their own, and we keep in touch. And it's very there's a very strong emotional bond between the neurosurgeon and the patient, particularly in pediatric neurosurgery, where we often become like a member of the family over time.
Wow. Yeah, that is really unique. A lot of times we use a doctor for a specific thing. Even a surgeon, I had a hernia surgery a couple of years ago, and it's like I've not kept in touch with the doctor, but certainly hernia surgery is not truly. It may be bringing mobility and comfort levels back to normal for me, but it's not really it's not giving me a second chance at life, like removing a tumor or getting a tumor under control. Um, so tell us more about your field of work there. And so it's a pediatric neurosurgeon.
Yeah, and I work with a team here of pediatric neurosurgeons, and in brain tumor surgery, we have teams of oncologists, the medical specialists in brain tumors, and neurologists, the diagnostic people, the neuroradiologists, the intensive care team, nursing, child life. It's a whole group of people dedicated to trying to get the child back to his or her life.
Mm.
What I tried to do in this book is try to bring the reader up to date about what's going on in the current business of medicine. And again, it's a powerful field. We have the electronic health record now that we didn't have when I was in training, and we can enter data into the computer. We can share data across the world, and it allows us to do a lot more than we could do without it. But also, it has to be managed because the electronic health record can become a sterile coder. It can lead to burnout. A lot of doctors and physicians and surgeons stay late hours in the night getting burned out doing all the charting. And sometimes the trainees will tend to copy and paste notes such that we have so much information that it becomes useless with garbage in and garbage out.
Mm.
But one of the problems in the modern era of the business of medicine is that we spend so much time on the computer that sometimes if you go visit your physician, mine is a great family practitioner, my own, but sometimes you look at the back of your physician's head while he or she's entering data into the computer. And I think it's wise for the physician and the surgeon to remember from time to time to take your hands off the computer and put them on the patient. It's one of the oldest traditions we have in medicine, and it tends to get lost in this era of technology. The doctor has become a care provider, and the patient is a client. And I think that the doctor-patient relationship is much more than that. We're not really only healthcare providers, but we have a very significant bond, and that's that bond that needs to be preserved. And if we don't pay attention to it, then technology, with all it can do, is not going to heal. Technology will treat the disease. Humanity will heal the patient. We need a combination of both.
Wow. Yeah, that's very powerful. And certainly in my field of counseling, I think many times you're right. We get so busy into creating notes or treatment plans and things like that, and we forget the simple questions like, "How are you today?" You know, what's the heaviest bag that you're holding today? And when you start asking those type of questions, you're revealing a little bit of your own humanity and knowing that all I'm trying to do here is make a connection. And I feel like that's really where a lot of healing begins is just human to human connection. So it's good to hear you state that. Hopefully my doctor at the VA will never listen to this, but I'll state that he's one of those head buried in the computer and let me get you out of here as quick as possible.
The thing
I
is, well,
wish.
the thing is that, kind words are not going to take a tumor out of anybody's brain. It's a combination of things. But these are things that sometimes it's some of the simplest things we do are the ones that are remembered by the patient. For example, you can imagine what it may be like for a parent who's never met me before, hours later, to surrender their child to me, a
Mm,
complete stranger in the OR for 8, 10 hours while they don't know whether the child's going to come back alive or whether the child's going to come back well. They're scared out of their wits. It's a terrifying ordeal. And some of the simplest things we do in pediatric neurosurgery, we've done now designer head wraps. So the child comes out looking like a bear or a monkey or a unicorn. And uniformly, it brings a smile to the family, no matter how serious the problem, and to the
mm.
child as well. Now we even have the kids giving requests for their designer head wrap before surgery. It helps the healing. And the healing, what I'm talking about, the humanity aspect, is not something obtuse. It's the basic, simple things that we do in terms of caring about patients or about each other, is kindness and empathy and compassion and optimism, humor, hope, things like that. But if you focus on technology, then the patient becomes a disease. We want to remember that the patient is a person.
Yeah. So whenever you think about the words comfort always, tell me what you thought of whenever you first started writing this book, or at least came up with the title.
Well, I chose the title. It came from the work of someone who lived in the 1800s, and he was uh, Edward Trudeau, Edward Livingston Trudeau. He's the great grandfather of Gary Trudeau of Doonesbury fame. And he was living in New York City, and his older brother James contracted tuberculosis, which had no cure at those times. So he cared for his brother who died. And then Trudeau went to medical school at Columbia in 1870, and he contracted tuberculosis at the end of medical school. And again, there was no antimicrobial treatment. So he went to upstate New York to the Adirondack Mountains and opened a sanatorium and came there just for the fresh air and nutritious food. There was no antibiotic treatment. And he got better, and he opened the sanatorium, the little red cottage, and it became bigger, and thousands of patients, including Robert Louis Stevenson, came to visit him there for treatment when all he could do is be compassionate.
Mm.
And he died in 1915, and 1,200 of his patients got together, and they hired a sculptor to create a statue for him, which still stands at Saranac Lake, which is a research facility now. And it's a bronze on marble statue of someone lying in a recumbent position when it was supposed to be Trudeau with a blanket over him. And it has the phrase, guérir quelquefois, soulager souvent, consoler toujours. And that translates to cure sometimes, to relieve often, to comfort always. That was one of his favorite phrases. And that's where the comfort always came.
Mm.
One of the problems choosing that title, though, is I wrote this book. Friends of mine went on to Amazon to make a comment about it. They told me when they typed in comfort always, they got directed to a tampon agency. So I said, I can't really vouch for that, but but maybe I should have changed the name. But it's a powerful quote. It actually came from Ambrose Barré, a French barber surgeon in the 1500s, who was considered one of the fathers of general surgery. But the power of comforting is something that we tend to forget in the age of technology.
Yeah. Can you speak about treating disease versus healing a person, and maybe how you first looked at that maybe being different from each other?
Well, I think it's important to have these technological adjuncts that we have. We have now microscopes and endoscopes and exoscopes that can magnify and let us see things. Well, we have antibiotics and anti-seizure medicines and steroids that we can use to treat. We have imaging and intraoperative neural monitoring. So we can do things that couldn't be done even decades ago. There was a guy, Moses Maimonides, about 1,000 years ago, who was a teacher, a philosopher, a rabbi, and a physician in Egypt, a Jew in Egypt, who said, may I never forget that my fellow is a patient, is a creature in pain. May I never consider him merely a vessel of disease. And that's the
Mm.
important point that I was trying to make in this book, that the patient is a person. And it's easy to see in this age of the business of medicine that I have 2 tumors in the emergency room and 3 hemorrhages in the intensive care unit and a broken back. But the patient is a person, not a disease. And the idea is we're trying to treat the patient, not the disease. One of the founders, Johns Hopkins, is one of the major institutions worldwide in medicine and surgery. And one of the founders of Johns Hopkins was William Osler. And in 1889, he left the University of Pennsylvania to become the first physician in chief at my institution, Johns Hopkins. He was a brilliant man. And he famously said, the good physician treats the disease, the great physician treats the patient who has the disease. So that's the distinction. Every case is different. There's always a balance between honesty and hope. It's never the same. And it's the job of the doctor to find that balance and remember that we're treating the patient, the person, not the illness.
Yeah. I think my biggest question is, how do you prepare yourself for a conversation with parents? And I'm sure, in many cases, a child is present with you. How does that work, and how do you prepare?
It's a good question because it's different in every case. There are some families who, in an attempt to uh, protect their child, don't want to let him or her know anything. They ask the child to leave the room, and they don't want the child to know anything until they're whisked off into the operating room. And sometimes that can promote more fear. So what we try to do is see how much the child and the family want to know. Every case is different, and no two cases are the same. There's no one size fits all. There's a famous oncologist from Toronto, Robert Buckman, who said, before you talk, hear. And I think it's an important aspect of the doctor-patient relationship is listening. So too often we just get involved in a conversation, and there's a lot that can be learned by just sitting there and listening. And sometimes it's a little bit awkward to have silence, but what it does is it helps the connection between the doctor and the patient and the family. So I would say, the issue is don't be afraid of silence. Don't be afraid to listen. You're looking for all your senses to try to find the best way to handle the patient that you're dealing with and the family that you're dealing with. And every case is different.
Yeah, and I think so many times we often want to fill in that empty space. In fact, whenever I was in school for counseling, that was one of our techniques. They're like, you don't have to always be filling in the gaps with your clients. Sometimes just be quiet and let them fill that space. Because I feel like sometimes if we try to fill that empty space, sometimes we can harm unintentionally, right? With some kind of word, some kind of shock factor that maybe they weren't anticipating just because we didn't take the time to fill out in my case, a client, or in your case, a patient. Um,
Yeah.
what are your thoughts on that?
Well, it's a difficult issue because nobody wants to deliver bad news. And in this case, we have to give news and we have to do it in an honest but compassionate way. The important point to remember is not to sugarcoat the news. We want to give good news, but we want to be realistic as well. And so I think this is an issue of compassionate honesty. There are ways to do that. But the important point is not to sugarcoat something and say something that's not true. The important point is to develop a trust between the doctor and the patient. And
Hmm.
by doing that, you share hope and share disappointment. The hope would be that the patient will want to come back to the doctor no matter what the situation is and fight this problem together.
Hmm. As a parent, we want to protect our children as much as humanly possible, but how many times do you see parents blaming themselves for something that clearly is not their fault?
Very often, and we have to work with that. It's a devastating diagnosis, and there's no one more important than to a parent than a child, and it's a very, very difficult thing. But sometimes, with the resilience of the child, that can help the family get through the ordeal. I've seen that on more than one occasion.
Hmm.
But you're right. That's a very important point. They blame themselves many times and when it's nowhere near that of an issue. This is hundreds of years after we've been dealing with brain tumors, we still don't know the cause of many of them, why this happens. There's a lot of that has been done in research, and but it's a normal fact to say, why is this happening to my child? What did I do wrong? I try to relive your life, and
Hmm.
almost all the time, there's nothing different that the family could do or should have done.
Are brain tumors, like, is there a hereditable factor with them, or is that on the lower side of things with brain tumors?
Well, I said that, with all this research that we've done, we still don't know the cause of most brain tumors, but there's a tremendous field now in molecular genetics. And yes, there are genetic factors that are responsible for a number of brain tumors. And in the past, what we used to do is we would remove a tumor and we would look at it under the microscope and make a diagnosis. This is a glioma, this is a medulloblastoma, this is a meningioma. We give it a name. Now, the World Health Organization, with molecular biologists, we have a hybrid diagnosis, so we can give that name, but we also look at the tumor under the microscope at the DNA and look for mutations. And some of these mutations, if we can't remove the whole tumor, some of them can be targeted. So we have now an era of personalized medicine where we can do things in the OR, and if we can't get the whole tumor out, we can often control it and prolong life and even have children live a normal life even if the tumor is malignant.
Yeah, I actually had a grandmother that passed away. I'll say with a glioma, and one of my best friends lost his father to glioblastoma 2 years ago, and it's I guess there is this scare, this terror when we hear brain tumor. And in a lot of ways, it's about maybe loss of function. Like with my friend's father, he definitely took on some different personality traits than what he once had. How often do you see that in children that maybe they're not quite like themselves?
Well, you can see that depending on where the tumor originates, but you mentioned the glioblastoma. That's the most common primary brain tumor in adults. It's the tumor that led to the death of Senator Kennedy and Senator McCain. It's a highly malignant tumor. There's a lot of research being done in the treatment of glioblastoma.
Mm.
Still, it's not a tumor that we can cure, but we can prolong life. Children have different types of tumors. Gliomas are glue-like. Glioma comes from the Greek word glue, and there are low-grade and high-grade tumors, but glioblastoma is not a tumor of childhood. There are many other types of tumors of childhood, and some of them are malignant. And one of the problems with brain tumor research is that there's a tremendous amount of federal funding for adult tumors such as glioblastoma. But in childhood, there are many, many different types of tumors, some benign, some malignant, and it's hard to get federal funding because there's so few tumors in each of these categories. So we're struggling with that. But I think the advances in brain tumors are going to come from molecular biology now that we can look at these things on a molecular level, at the DNA level, and develop treatments, adjuvant treatments, medications that would be more toxic to the tumor and less toxic to the patient.
Mm. I'm a big guy with humor. I try to use humor in my office space a lot. What are your thoughts about using humor with parents or patients or even with your staff?
Yeah, I think humor helps healing, and it's an important adjuvant in treating patients. Humor is vitamin H. They say a merry heart doeth good like a medicine in the Old Testament. Uh,
Yeah.
and which, in my mind, is not to say that we need to stand in the intensive care unit doing stand-up comedy at the bedside, but particularly in my field dealing with kids, humor helps to break down the barrier between the doctor and the patient, making yourself more vulnerable. Allows you to develop a rapport with a child, make yourself vulnerable, and humor helps healing. It can even help the immune response. It strengthens the child, and in a time of a difficult time, it has a very important role.
Excellent. Well, I want to hear some of your stories. Um, give me something that you think's impactful from your book, and correct me if I'm wrong. You kind of I guess dedicate this book to your young patients and your parents out there. I guess.
Yeah, because for allowing me to tell these stories, I have not changed the names. I got permission, and I think it's more realistic because these are true stories. And the idea was to take the reader into the bedside and see what goes on in real life, to talk about what it's like for a parent to hear of a diagnosis of a brain tumor in their child, and to go through the surgery and the treatment and what happens in the emotions that go on. I tried to talk a little bit about the mystery of the nervous system. The brain is the most complex organ in the universe. It weighs only 3 pounds and it's about 75% water. But there's about 100 billion neurons or nerve cells in the brain, and they have trillions of synapses or connections, and that's what is responsible for our entire consciousness. There's a
Mm.
mystery, but there's also a beauty, a magnificence of the brain, and to try to be able to, at the bedside, make a diagnosis on the basis of a history and a careful examination. It's like a detective story. So that's what each of the stories that came over the years. One of them, they're all powerful stories. One that I remember very vividly was when I was in Boston. A mother called me up. I was working late in my office from out of state about her 2-month-old daughter. And The mother was very sophisticated because she had worked as a neurology and neurosurgery nurse. And she was pregnant. And at about 20 weeks, she was diagnosed that the baby had Down syndrome, a genetic disorder, trisomy 21, which is a tough hit. But then they did a fetal ultrasound, an ultrasound through the womb here, and they found that the child had a malignant brain tumor filling the left hemisphere of the brain. This is at 20 weeks gestation. And
Hmm.
the family underwent counseling, and the compassionate team felt that out of the best situation, rather than have the baby be born and spend time in the intensive care unit, they arranged to have the family take the baby home and nurse the baby at home so that she could die without being in the hospital. This
Hmm.
mother wrote eloquently about what it was like to be told that her unborn daughter was going to die of a malignant brain tumor. And serial ultrasounds and MRIs while the baby was in the womb showed that the tumor continued to grow. And sure enough, the baby was born. Another MRI showed that the tumor was even larger. And mom took the baby home with plans to die. And she wrote eloquently about how difficult it was. She didn't have any clothes for the baby. She didn't make any plans. They took the child to the ocean so that she could dip her feet in the water and feel
Hmm.
the ocean and touch the sand, thinking that the next time they would be there would be to bury their daughter, to bury their ashes. And then she called because after about 2 months, the baby stopped getting worse. She originally needed nasogastric feeding, but she started feeding, and the baby didn't get any worse. And she was wondering what's going on. And so she flew up, and we took a look at the baby, and she was getting pink. And sure enough, she had this big tumor filling the left hemisphere of the brain. And we said, we're not sure what's going on, but we don't want to give her a death sentence. Let's take a look in the OR. And so we went to the OR and turned out that it was not a malignant tumor. It was a big tumor. It was an unusual tumor. It was masquerading as a malignant tumor, as a brain cancer, but it was what's called a DIG, a desmoplastic infantile ganglioglioma. The important thing about that is it's a benign tumor, WHO grade 1, not cancer. We were able to take it out. The child is alive now, 11 years later. She's in the fifth grade, two boyfriends, and she loves to dance and smile and are loved by her family. And it's a child. And what was gripping about that is the resilience of the mother and the family and the powerful words that she wrote. What was like to go through the grief of planning to bury your unborn child. There's nothing more moving than something like that. So that's a happy case and it's a happy story. There are many happy stories in neurosurgery. We're not dealing with ingrown toenails. It's a tough ride, but the outcome in a case like this is much, much worthwhile.
Yeah, and it's one of the first times that I guess I've heard anticipatory grief actually making a turn for the better. Usually, when I talk about it on this podcast, we speak about dementia or Alzheimer's, and we see this uh, person really in an ambiguous grief as well, knowing that, okay, the body's there, but maybe the mind is gone. And we start that anticipatory process of thinking, I'm going to lose this person. And then, of course, finally, a finality in a real grief where physical loss occurs. So, but to hear that this lady was really given false hope from the beginning, it sounds like, and she
Well,
started anticipating, but then found a hope that turned this thing around. That's unusual and wonderful.
I think it's important, though, for counseling and for a physician or surgeon to have that correct balance between honesty and hope. That is, the physicians were very honest with the family. We don't want to give false hope. In fact, when we saw the child, we said most of these fetal brain tumors are bad actors. Most of them don't survive. It was a little bit unusual. We thought there could be a chance, and but we didn't want to give false hope. This balance between honesty and hope. It was, I think, Mark Twain who said that I have too much respect for the truth than to drag it out on all trifling occasions. He was a humorist, and it's not so much that, but it's trying to find that right balance because you're right. We don't want to give false hope, and we didn't know what this was going to be. Most of the time, it's not good news. But in a case like this, you take a chance and get lucky sometimes.
Sure. And I'm sure, being a neurosurgeon, you've been on the other side of that equation as well, where uh, someone didn't make it or had a prognosis that just wasn't good. And how do you deliver that news, and how does it affect you personally?
It's a very hard act, and everyone that cares for patients with brain tumors, particularly children, have to deal with it. And we feel the grief. We're taught to try to distance ourselves from the patient because you
Mm.
have to be able to do that to give adequate care. But I don't agree with that. In other words, we're human beings as well, and I think it's important to express our emotions, and we want to share hope and share disappointment. And sometimes the whole team needs counseling because it's tough. On the other hand, some of these families are unbelievably resilient. And what I've told you before is that sometimes the child is resilient. We had a girl who had a malignant brain tumor in her thalami between the two hemispheres of the brain that we operated on about 25 years ago when she was 9 years old. And she collapsed it. She collapsed in a pool. Her name was Emma. We collapsed in a pool, and her mother was there taking pictures. The lifeguard didn't see this, and the mother happened to be taking a picture of her daughter, watching her collapse in a pool. And it turned out that she collapsed because she had a seizure. And we had to operate on her. It was a malignant brain tumor. We resected the tumor, but she required 2 years of very aggressive chemotherapy, which had a lot of side effects. And it was a difficult ordeal for anybody. Now she's in her 30s, she's an artist, and she's an advocate for cancer survivors. And it was her resilience that with mom, stop crying. I'm going to get through this. And she got her family through something like this, and now she's helping others. So the resilience of the patient, the resilience is something very, very powerful. And I've seen it more than once.
Yeah, that's amazing when a child becomes the comforter of the parent, even though they're the ones that's going through the difficult time. Of course, that's not to take anything away from mom and dad and even siblings. And a lot of times in grief, we talk about how a sibling that say a brother lost his sister and somebody goes to comfort, they go up to him and say, "How's your mom and dad doing?" We kind of overlook certain parties in this. How do you think, we'll just say secondary members within the family are still a part of this process as well?
Yeah, that's an interesting point. And, one of the most powerfully emotional things that I ever do is to meet the family in the waiting room after a long operation. The family is there for sometimes 8, 10, 12 hours, not knowing what's going to happen. And it's always emotional and hopefully more often happily emotional than not, but always everybody's in tears. And there are people who don't know what to do with the family. I don't know what to say. They're afraid to approach the family. And I think the important message there is it really doesn't matter. It's just
Mm.
being part of it is what's important. And some people have an extended family there, some have friends. But just being there, there's an anxiety because everything's unknown. Most people don't have an experience with a significant illness or particularly a childhood brain tumor. But supporting the family is just a measure of being there. And there's no one way to do it.
Yeah, I often joke about me. I state I want to write a book called The 100 Dumbest Things that I've Heard at a Funeral. I'm sure that you could say the same thing about the 100 dumbest things you've heard in a waiting room as well. Like you said, we're not master comforters by nature, and often we start stumbling over our words, and like you stated, I think sometimes it's just simply being present with someone in a time of need.
Sometimes just sitting there in silence is all that's and people remember that. As I said earlier, they often remember things. We do a 12-hour operation, and what they remember is, oh, I remember when you put the cover back on my son or something like that, or I adjusted his pillow or
Mm.
put the dressing on this little teddy bear. It's the simple things that sometimes go more distance than we would think. When there's a famous picture of William Osler, who in his era was the most famous physician in the world. He was sitting at the bedside of a young girl playing with her dolls with her. And that just says something about the power of that connection.
Yeah. You had talked about technology, and certainly across 4 decades of being in this field, I'm sure that it's not just charting that has changed. My wife is in the medical field, and I hear her. She's gone through many things, and the one I've heard her complain about the most is Epic. I don't know anything about
That's
you.
the electronic health record. Yes,
Yeah,
the
yeah,
bane of our existence. It's a great device, uh,
yeah,
but it can cause burnout. And
sure.
again, some people consider it to be a sterile coder.
Mm,
It can do so much, but it needs to be managed. Technology needs to be managed. And there are codes for disorders. When we do an operation, we put in a code. But did you know that there's a real code for being sucked into a jet engine, subsequent encounter? That's a code. Or other contact with a cow, subsequent encounter.
wow.
It's gotten a little bit crazy. The pendulum has gone too far in the other direction. So it's a powerful tool, but it's very time consuming. I think we need it, but we need to manage it. Just like with AI, with artificial intelligence, that
That's
was
where,
not there when I started. It's
yeah.
advanced, it's turbo computing.
Well, and that's where I was going to go next is your thoughts on AI. And to me, I've often mentioned it's like a loaded gun. I can get my next meal with it, or I can really it could be harmful as well. It just depends on how you use it. And certainly, I see things going on in my field with it where people use it to dictate notes and things like that. But I can also see where if something is falsely imposed onto an account or a client, how that could have a future fallout if we're not really, really careful. How does AI come into play with your field, sir?
Well, I think it's coming down the pipe very quickly, and uh, I hope that it's going to be something that's going to aid our field and we're going to be able to manage. But I do have some concerns. I think the great physicist Stephen Hawking said that AI has the possibility of ending humanity.
Mm,
He was a bright guy, and that's a scary thought about whether we're creating tools that could be smarter than we are, that can take over things. I kind of hope to agree with the chess grandmaster, Garry Kasparov from Russia, who said that I don't think AI is going to replace humans, but humans who use AI will replace those who don't. I think if we can manage it, just like with the artificial or the electronic health record, it will have much that it can do, helping to write notes. I don't use it for that. But for example, if we have a complex brain tumor, if we're able to compare that to 10,000 other images from AI, it can help us make a diagnosis. I don't think it's going to replace the doctor or the surgeon at the bedside because a lot of what we do is based on nuance and gray zones. We think that we have an answer for everything, but we have to do a surgical judgment, whether to operate, whether not to operate, how to operate. And I think that there's going to be a human touch that's always there. It's the Frankenstein fear that people have if this is going to get out of hand, and I hope it won't, but I think it's going to need to be managed. When I go on Facebook now, I have trouble determining what's real and what's not because some of the pictures videos that they can make with AI is unbelievably good, and it could have an unbelievably bad impact if it's not managed.
yeah, it is getting very, very close and to I guess close to real life in some of the videos that I've seen as well. And it's like, wow, I you really have to pay attention, whether it's looking for an additional digit on a hand or, something that kind of slipped into the video before you're like, I don't know about that. That doesn't look so real after all. But but I can certainly see where it does have its advantages in medical, whether that's mental health or physical health. But like you stated, I think good management is probably where we're at. As far as surgery tools and things like that, technology, I'm sure, whether it's laparoscopic or things like this, um, I'm sure that has changed a lot over 40 years too.
Yeah, and we have, a bunch of instruments that Maimonides 1,000 years ago could never have dreamed of. Where we have magnification with microscopes and endoscopes, lasers, miniaturized instruments. We can do what we call minimally invasive surgery by not disrupting much. We go through small incisions. But there is a guy, Ronald Weinstein, who's the father of telepathology, who said, a fool with a tool is still a fool. So,
Mm,
at the end of the day, it's surgical judgment that's the important thing. We can do things and we can do things more safely, but it's not the tool, it's the surgeon that's going to make the difference.
mm. Whenever I think about your job, you're certainly the surgeon and you're also a witness to this suffering. How does that come into play, especially when we're looking at, you talked about an 8, 10 hour surgery. Like what do you do to take a break there just to refresh?
Sometimes the nurses in the OR manage our cases by the calendar, not the clock. They can go for a long time. But when you're
Mm,
operating, you get sort of an adrenaline rush, and you can concentrate. It's afterwards that you kind of break down and fall apart or go to sleep. We
ooh,
sleep well. I sleep in conferences if they turn the lights down. That's an issue. But you get used to it, and it's tough. But I think it's the gratification of knowing that you're doing something that's really important, affecting the lives of someone else and others that keeps us going.
mm. On this podcast, we often deal with, the end of life and speaking about really the thereafter for those who are grieving. Um, what is the aftercare like for parents who have lost a child to a brain tumor?
It varies. I think what's helpful is that one of the patients that we cared for was a child who had a highly malignant brain tumor. His parents were very sophisticated, and in spite of all the surgery and the best available care, this was a highly malignant brain tumor in a young child who did not survive. And the mother wrote a book about the ordeal and has dedicated herself to fighting brain cancer in children
Mm,
and to the memory of her child who did not survive. And so it's very, very moving, some of the ways people respond to this. And some people use faith to help them get through. Everybody does something different, but to try to remember the child for what he or she was and never forget, the memory would always be a blessing.
mm. If there were a frightened parent listening to this right now that may be facing this with a child, you talked about always wanting to offer hope. What kind of hope would you offer them, and what kind of advice would you give them, especially if it's early stages of at least identifying a brain tumor?
I would give advice that hope helps healing, and every case is different. Controlled optimism, there's always a way to try to find a silver lining in even the darkest cloud, and that's what we try to do. And if the goal is to try to cure the tumor. If we can't control the tumor, the goal is to manage it to get the child back to his or her life. And some kids, even with highly aggressive malignant tumors, can go back and live a normal life. And if they can't, we give them the best life that's possible. And with all the tools that we have now, and with the doctors and the healthcare team that can be at the bedside and help the family, hope helps healing. And when there's life, there's hope.
Hmm. Well, it certainly still, it sounds like you still believe that we live in a time where hope is available. And I really do believe with technology and just things that we have available today, I wonder how many people from yesteryear would still be alive with all the technology and things that have changed over the years. We may have way more population than what we would ever assume.
Yeah, President John F. Kennedy had a baby born prematurely who did not survive in the NICU because of the number of weeks preemie that baby was. Today, that's a child who would routinely survive and go home and live a normal life. Technology does make a difference.
Yeah. Al, it's been an absolute pleasure. I really appreciate you coming on and speaking. And I want to give you certainly the final words, but also anything else that you would like to tell the listeners about your book besides go pick up a copy and read this. And where can they find copies? Amazon, I'm sure. Where else?
Yeah, I just recently wrote it. It's the first time I've written for the public. I hope you enjoy it. I think it was meant to reach a broad audience, both people in the medical profession and the non-technical reader, because I hope you'll enjoy the patient stories. It's on Amazon, but as I said, for people who want to make a review, if you just put Comfort Always, you'll get taken to a tampon site. So you have to put that with my name, and I hope it's a good read.
All right. Well, we certainly appreciate you coming on and sharing about your book, your career, your life, and I'm certain that you will continue to make a difference in the lives of many people. Thank you very much, sir.
Thanks for having me, Brad.
You're welcome. So, folks, again, check out Dr. Alan R. Cohen's book, Comfort Always Healing in the Age of Technology. It sounds like a wonderful read, and I need to finish reading it myself. And just go out there and support him and make a difference and maybe give it to somebody who needs to hear some comforting words. So, again, thanks for listening and come back for next episode, everyone. Have a great day.